All right, so looking at continuing our first lecture from part 1, this is part 2. Intake and screening of SUD involves determining, the severity and duration of use for clients. So we're particularly interested in the acute nature of the client's presentation, the level of drug and alcohol use, and for this we use a range of screening tools, which I'll be showing you. We're interested in any co-occurring mental health issues such as depression, anxiety, trauma, or psychosis, social and other health issues, welfare-related issues, and other risk management issues that we need to be aware of, such as suicidality and also self-harming behaviours, which link back to mental health issues that might be present for the client. So looking at screening tools and instruments, screening's conducted through generally structured interviews or by administering formal standardised tools that we refer to as instruments or inventories, and the selection of the instrument is based on various factors, the time you have, the appropriateness for the client, also their age and different presenting issues. And you'll be guided by your organisation in terms of an appropriate screening tool to use. How screenings and assessments are conducted is really, really important, because at all times we're wanting to be client-centred. We're not wanting to impose a process on a client that will either hinder your ability to develop a trusting sort of genuine connection with them, but at the same time you're needing to gather information. So the way in which you deliver that and frame it up to the client is really, really important. Now, a really common standardized screening tool for assessing alcohol use is called the Audit, the Alcohol Use Disorder Identification Test. It's widely used. I'm inviting you to Google Audit as a screening tool, and you will actually be able to see a PDF version, and I'll try and download that and put it into the unit announcements for you. But this Audit screening tool is a really effective way to be able to identify people with problem drinking, and it's generally used in Brisbane by organisations like Veteran Affairs or VVCS. It has 10 questions, and you're looking at hazardous, harmful alcohol consumption. It's self-administered, but also I've actually supported my clients by asking them the question depending on their literacy, if there's been any literacy issues, So it's been validated by many nations and the World Health Organization. It aims to screen and determine risk of drinking, so it might be low, mild, moderate, high, or acute. It helps to identify the frequency of drinking and also the quantity, so the intensity of use. And it can be used both with men and women at various ages. So we determine that someone has an alcohol dependence if they end up having a score greater than 20. And actually I've given you a PDF form of it by just clicking there on that link I've provided. Now, what we're wanting to do is assess the severity and duration of use. So they've actually created a more contained version of this audit form, and it's called the Audit C. And clients are basically asked the following 3 questions. How often do you have to drink anything containing alcohol? How many drinks containing alcohol would you have on a typical day? How often do you have 6 or more drinks on one occasion? They've also developed something called the Audit, and Berman and all developed this back in 2003, and it's basically along the same principles as the Audit, but it's looking at drug use in particular. So that's something to follow up as well for your assignment. There's another tool called the Severity of Dependence Scale. It was originally developed for assessing psychological dependence on heroin. However, it's now used across all types of illicit drug use. And I guess what you're wanting to see is the relationship that the client has to a particular substance. We have the CAGE, which is another screening tool, again, that looks at alcohol and drug consumption. Each yes response is allocated a point of 1, and 2 yes answers results in a very small false positive rate. The clinician would be less likely to identify clients as potentially having a substance use disorder when they don't. But we're looking at a sort of different questions like, have you ever felt you should cut down on drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had a drink first in the morning to steady your nerves or to get over a hangover? So these types of questions, I think, don't stand alone. They're really great in terms of opening up more in-depth conversation about the context of a client's particular drinking habits. Assist is another screening tool that relates to alcohol, smoking, and substance involvement. Again, it was developed by the World Health Organization, and I've given you a link there to be able to read through the manual and have a look at whether it would be appropriate for one of the case studies you need to look at in Assessment 1. And then the CRAFFT screening has been specifically created for adolescents. It comes out of the US. I haven't seen it used too much in Australia, but currently in my workplace we are using it as a trial to see whether it assists us in terms of really identifying some of the problem behaviours for our young people using alcohol in particular. So something to look at and investigate for your assignment. So let's shift out of these screening tools and remembering again that we undertake screening in order to determine whether further assessment's required. Now, assessment needs to be really comprehensive, so we often refer to assessment in this area as being a biopsychosocial assessment, meaning we're interested in any sort of genetic predisposition to use any psychological factors, and also the developmental factors or social, environmental context in which use occurs. Now, we're also really needing to assess our clients' psychosocial needs and to ask questions like, what are the client's immediate needs? Food, shelter, what's the background or family of origin context? What's the drug and alcohol history? We also need to have a sense of where the client is in terms of their readiness to change. There might be fear related to change, and we'll certainly be looking at change and motivational interviewing in next week's lecture. We're screening for psychological or mental health issues, and providing clients with our feedback around those initial assessment thoughts. I think a really great model to inform that assessment of psychosocial needs is that by Abraham Maslow. Many of you may already have been exposed to Maslow's hierarchy of needs, but basically it's this pyramid is based on different types of needs that we encounter throughout the lifespan, and Maslow believed that if those needs were predominantly met in a safe environment, then that increased our potential to experience self-actualization. Now, I don't know many people who've self-actualized, but certainly it's about being on that journey towards achieving our potential. Now, for many of our clients, we need to remember that their basic physiological needs aren't in place, and we need to have a clear sense of what's happening for them before we kind of step in to doing more of the intense psychotherapy with them around self-esteem or love and belonging. Not to say that they're not important, they absolutely are, but if you've got a client who's come into counselling and they haven't eaten for the last 3 days, then that's going to undermine any type of counselling work that you're doing with them. So just keeping that in mind, I think that having a sense of or being able to meet the client where they're at is a really important skill that we bring to all client groups. Now, Marsh and Toole, your textbook, talk about how to conduct a risk assessment, and the idea of this for me is really about, again, wanting to understand the benefits of a particular behavior versus the negative consequences. I think that traditionally that medical model would come in looking at only the deficits associated with a particular addiction. Now we are far more holistic. We're wanting to understand what a person gains from their use. So I've kind of created this table for you, kind of outlining risk factors that kind of might keep a person in addiction and or really ambivalent about changing versus protective factors that might present in their life that that will help for them to shift into a different state of being motivated towards change. So let's look at some of these risk factors. Lack of readiness. So the client might be in a state of denial still or highly ambivalent about their actual addiction. They might be very isolated and lack a number of natural supports. So they might be estranged from family and friends. Also, they might be very wary and mistrustful of formal supports and systems like counsellors and other agencies that want to intervene. They might just be sitting with learned helplessness. Maybe they've tried to give up several times and have failed, and so they have this defeated mindset, which causes paralysis around change for a lot of people. Another risk factor is dual diagnosis. When we know that a client is presenting with, co-occurring mental health issues. Polyuse is a risk factor because generally someone will have a preferred substance and then begin to use other substances for a range of reasons, and we'll learn more about polyuse as we go, but that is a risk factor in terms of helping people into recovery. People with a high external locus of control, that is, they have a very limited sense of self. They tend to externalize blame on others. They really struggle to master their behaviors, and they really don't have a sense of responsibility for their behaviors or any sense of the impacts that it causes to themselves and others. Also, when we're seeing that all areas of functioning are impaired by someone having a relationship to a drug or substance, we talk about that being a risk factor, so impaired functionality. Some protective factors include a readiness, motivation to change, someone who's engaged in counselling, they're using the therapy well, there's a number of natural supports, there's help-seeking behaviour, there's reflective awareness, a high locus of control, so they have a sense of internal self-efficacy. They do take responsibility. There is awareness, and there's other areas of functionality in their life. So they're studying, they're working, they've got some relationships that are still intact. They're describing, they're demonstrating insight and reflective awareness to you. And there are exceptions to their story that suggest that there have been times when they functioned very well without the substance. Now, I might leave it here because during our BBC, we'll be looking at case conceptualization together and some of this screening and assessment information. I hope you enjoyed the lecture.